very well known about many antiplatelet trials, especially including the cilostazol. And today he will give us a talk with the title of the Randomized Controlled Trials for Asian-Specific Treatment Strategy. So please, Kazu.
Hello, this is Kazu Toyoda from Osaka. I am happy to get a chance of speech about RCTs in Asia. First, I introduce past and present paper production potential from Asia. In 2012, an interesting and shocking report was published in Stroke. The left panel shows citation fractions on article about stroke. Japan produced 8% of the articles over the world, followed by Korea, China, and Taiwan from Asia. However, the right panel shows the contribution to international collaboration was very low in any Asian countries, even Japan. They were all like the Pluto of the solar system. Time has passed. The circle graphs show the recent share of papers on any clinical medicine, not stroke medicine, by country. China produces around 1/10 of the articles over the world, followed by Japan and Korea from Asia. The world map indicates percentage of the number of cited articles in stroke in 2019. More than 25% was from the United States. The second largest was China. Papers from Japan and from Korea were between 4 and 11%, and those from India and from Taiwan were between 1 and 3%. China has obviously acquired solid power. Next, let's check recent known RCTs from Asia. Chance from China is one of the masterpiece RCTs from Asia. Among 5,170 patients with TIA or minor stroke, all registered in China, who can be treated within 24 hours after the onset, the combination of clopidogrel and aspirin was superior to aspirin alone for reducing the risk of stroke in the first 90 days and did not increase the risk of hemorrhage. This was the first clear RCT that proved the strong impact of acute dual antiplatelet therapy after stroke. 56% of the registered patients had intracranial arterial stenosis. This prevalence is specific to Asians. There was no significant differences in the response to the monotherapy and dual therapy between patients with and without ICAS. Secondary stroke prevention using cilostazol can be called as Asian-specific treatment strategy. Cilostazol was made in Japan and prevalently used for secondary prevention of non-cardiogenic stroke in many East and Southeast Asian countries. CSPS trials from Japan were published every 10 years. In the first CSPS, cilostazol decreased the risk of recurrent ischemic stroke by more than 40%. Surprisingly, bleeding events were similarly common between the cilostazol group and placebo group. The second CSPS was a head-to-head comparison between cilostazol and aspirin. Shirostazole decreased the risk of any stroke by 25% and decreased major bleeding by half. After this CSPS2, Shirostazole was approved as a Class A antiplatelet agent for stroke patients in Japanese guidelines. In the recent CSPS.com, the combination of Shirostazole with aspirin or clopidogrel had a reduced incidence of ischemic stroke recurrence by half, and a similar risk of severe or life-threatening bleeding compared with treatment with aspirin or clopidogrel alone in patients at high risk for recurrent ischemic stroke. Korea is another country with several stroke RCTs using Shirostazole. The recent Picasso trial was a 2x2 factorial trial. In patients with ischemic stroke at high risk of cerebral hemorrhage, Shirostazole was non-inferior to aspirin for the prevention of the composite of stroke, MI, and vascular death, but did not reduce the risk of hemorrhagic stroke. Addition of propofol to aspirin or Shirostazole could be beneficial for reducing the incidence of cardiovascular events. Stroke thrombolysis using 0.6 mg per kilogram alteplase would be another agent-specific treatment strategy. This low-dose therapy is officially approved in Japan, and several Asian physicians choose this low dose. We wanted to try a head-to-head comparison of 0.6 versus 0.9 in Japan. But it was difficult, partly because the government did not seem to allow our use of 0.9 in Japan, even as a trial. Professor Craig Anderson achieved this comparison in Enchanted trial. 63% of the overall 3310 patients were from Asia. Enchanted did not show the non-inferiority of 0.6 alteplase to 0.9 with respect to death and disability at 90 days in the overall cohort or separate cohorts of Asians and non-Asians. There were fewer symptomatic intracranial hemorrhages with 0.6. The results of RCTs on intravenous thrombolysis for stroke with unknown time of onset were published successively in this couple of years. In November, the EOS study group published IPD meta-analysis of the therapy in Lancet. In patients developing an unknown onset stroke with a DWI flare or perfusion mismatch, intravenous alteplase resulted in better functional outcome at 90 days than placebo or standard care. A net benefit was observed for all functional outcome despite an increased risk of symptomatic intracranial hemorrhage. In the subgroup analysis, 0.6 mg per kilogram versus 0.9 was compared. Although thrombolysis was better in 0.9 cohort, the result was neutral in 0.6 cohort. This 0.6 cohort was equal to the SOCRATES participants that was performed in Japan. SOCRATES was an investigator-initiated RCT. The study design was same with the European wake-up trial, except for the 0.6 mg per kilogram alteplase use, and patient with standard care, not placebo, was set as a control. Overall, the two groups had almost identical percentage of the modified ranking scale of 0 to 1. Frankly speaking, the results of the control group was too good, and it was hard to show the significantly better outcome in thrombolysis group. In the sub-analysis, we excluded the patient with tiny infarcts. For example, when we compared the two therapies using patients with DW aspects of 8 or less, the thrombolysis showed significantly better outcome than the control. We are pretty sure that the low-dose alteplase is effective in Asian stroke patients with unknown time of onset. This sub-analysis will be published in Stroke Online before APSC 2020. SOCRATES was an international RCT to compare ticagrelor versus aspirin for secondary prevention of non-cardiogenic stroke. Ticagrelor was not superior to aspirin in reducing the primary endpoint, that was composite of stroke, MI, or death at 90 days. Although it significantly reduced a risk of ischemic stroke alone. 30% of the overall 13,000 patients were from Asia. Interestingly, ticagrelor significantly reduced the rate of the primary endpoint in the Asian cohort. Thus, ticagrelor alone may be useful for secondary stroke prevention in Asia. High event rate in the Asian cohort might make it easier to show significant intergroup difference. Similarly, RESPECT-ESUS showed different tendency of outcomes between Asians and non-Asians. In the overall global analysis, dabigatran was not superior to aspirin in preventing recurrent stroke in patients with a recent history of ESUS. In the subgroup analysis for patients from Asia, dabigatran was marginally better than aspirin. Note that this Asia included Russia. 11% of the participants were from Japan. In this cohort, dabigatran decreased the risk of recurrent stroke by 45%. The risk of major bleeding was similar between the two drugs. The positive result might reflect specialty of Asian stroke. In addition, frequency of MRI and MRA examination of Japanese participants was much higher than non-Japanese. And accordingly, ESUS seemed to be more accurately diagnosed in the Japanese cohort. Even under the same inclusion criteria and therapeutic design, Asians and non-Asians sometimes had totally different outcomes. Such messages from several RCTs raise a doubt if trial results from Asian stroke can be generalized to global stroke. In many stroke papers from Asia, authors described in discussion that results might not be generalized to other ethnics. In Chance, the authors described a long paragraph to explain special situation of stroke features and stroke medicine in China. The editor wrote in the commentary that the results might not apply to non-Chinese patients. At the time, the POINT trial was scheduled in the United States, and many researchers took an interest if POINT reproduced the outcome shown by Chance. I also show you an opposite example. When we submitted the first draft of CSPS.com to Lancet, we wrote that with ethnicity limited to Japanese, generalization of the present findings to other countries would be difficult. The reviewer criticized that it will not be enough to say that these results only apply to Japanese people. It is possibly true, but in general, biology across ethnic groups is more similar than different. We finally weakened our initial discussion. Anyway, I'm often complaining why we need to add ethnic limitation in discussion, although Western researchers seldom did. As you all know, stroke is an Asian disease. EPSC are sending a message that more than half of new stroke patients worldwide are Asians. In the first day of this EPSC 2020, Professor Ramani and Professor John S. Kim have a lecture on special features of stroke in Asia. Here, I briefly refer to the features based on our previous paper. Stroke in Asia is unique in the points of high incidence, high prevalence of intracranial atherosclerosis, high prevalence of intracerebral hemorrhage, effects of dietary and lifestyle habits, and several disorders with genetic etiologies. I'll show you a good example regarding arterial dissection. In Western countries, the extracranial carotid artery is a main focus of cerebral arterial dissection. However, in Japan, intracranial vertebral artery dissection amounts to 63% of the total cerebral dissection. Intracranial artery disease is a key point of Asian stroke. Intracerebral hemorrhage is another typical intracranial small artery disease. To seek optimal acute blood pressure lowering therapy, several RCTs were performed in this decade, such as INTERACT-2 and ATEC-2. More than half of the participants were from Asia in both trials. We compared clinical features of ATEC-2 participants from Asia and those outside of Asia. The article will be hopefully published in Neurology Online before EPSC 2020, or anywhere within this year. In ATEC-2, all the Asian patients were registered in East Asia. Non-Asian cohort was registered in the United States and Germany. Although the same inclusion criteria were applied, demographic characteristics and frequency of each risk factor varied much. As highlighted in red, initial NHSS score was lower. Basal ganglionic hemorrhage was more common. Lobar hemorrhage was less common. Intraventricular hemorrhage was less common. And onset to randomization time was 33 minutes shorter in Asians than non-Asians. Such a difference in time delay may reflect the difference in pre-hospital or emergent stroke care system between Asia and non-Asia. In ATEC-2, modified ranking scale of 4 to 6 at 90 days was 32% in Asians and 46% in non-Asians. The big difference in the percentage may partly be due to difference in the initial severity, hematoma location, IVH, and time delay. However, I'm not sure if such factors can completely explain the results. When the effect of intensive blood pressure lowering and standard lowering on hematoma expansion was compared, intensive blood pressure lowering was significantly protective against enlargement only in Asians. Thus, Asians or non-Asians may be critical prognostic indicator for ICH. Based on the findings that I presented, it would be better to perform trials including both Asians and non-Asian cohorts and perform pre-specified sub-analysis for each cohort. To enhance the worldwide RCTs, I finally introduced networks for global stroke research. There are some obstacles to investigator-initiated trial. Professor Mark Fisher described in Stroke when he was an editor-in-chief that repeatedly assembling the necessary personnel and infrastructure each time trial begins, and then disassembly each time trial ends, has made for an inefficient environment for conducting trials. In addition, overwhelming shortages of study coordinators and research nurses for staff education, administration of test drugs, data management, adverse event collection, biostatics, and other necessary tasks are essential problems in acute stroke center in Japan. When we held US-Japan stroke meeting in 2010, I had a chance to personally talk with Professor Joseph Broderick in University of Cincinnati. In 2015, Joe established NIH StrokeNet, a network for stroke researchers to enhance investigator-initiated stroke trials in the United States. NIH StrokeNet provoked us into starting the same researcher network in Japan. In the next, NCBC, my workplace, was set as a headquarters with a data management center and central pharmacy. Iwate Medical University was set as a central imaging lab and linked up with many stroke centers. For example, the SOULS trial was performed using this next system. Joe and Professor Andrew Demchek further established the network of networks on stroke research in each country. It is called GAINS and focuses on planning and performing global trials, mentoring young trialists and others. The first general meeting of GAINS was held in Niagara-on-the-Lake in 2016. From Asia, Professor John Kim from Korea, Professor Gerard Pandien from India, Professor Tsong-Hai Lee from Taiwan, Professor Craig Anderson from China and Australia, and our next group, Haruko Yamamoto, Masa Koga, and me attended. I show you an RCT planned in GAINS. In the last decade, we tried to develop recombinant factor 7A as acute therapeutic tool for ICH. In the phase 2B trial, factor 7A decreased % increase of hematoma volume at 24 hours and increased the rate of favorable outcome at 90 days as the dosage escalated. It was so promising. But the favorable effect of factor 7A was not reproduced in the phase 3 first trial. The pharmaceutical company gave up to continue the trials. However, in the separate analysis for patients with earlier than 150 minutes from onset, younger than 70, smaller than 60 in hematoma volume, and less than 5 ml in IVH volume, factor 7A significantly improved 90-day outcome. We plan to re-challenge the trial by investigator-initiated trial. However, as I explained, time delay from the onset to randomization was relatively long in Western countries, and it was a limitation. The spread of mobile stroke unit may resolve the limitation. Now we are planning the first test trial for ICH patients within 120 minutes. The trial is funded by NIH and partly funded by AMED in Japan. PI is Joe Broderick. 6 countries join, and 860 patients are planned to enter. Okay, this is my final slide. The first announcement of the 10th Korea-Japan Joint Stroke Conference. It will be hopefully held in late 2021 as a hybrid conference via on-site in NCBC Osaka and virtual meeting. We will change the plan according to the condition of COVID-19 infection. I hope that many Asian colleagues will attend the conference via web. Thank you for your attention.
Thank you, Kazu. So now the Q&A session is open, and we have our 2 speakers. I think I should say I should say good afternoon to Kazu and good evening to Michael. Hi. Yeah. So there are already 2 questions from the audience, and I think we have almost 10 to 15 minutes to discuss. So time is enough. And the first question is to Mike. How can you achieve a door-to real time of less than 30 minutes? Do you sometimes omit a laboratory exam such as the PT or APTT? So I wonder, the 30 minutes is the goal or the average, or I thought it was your target. Anyway.
Yeah, so thank you very much. Great question. Yeah, it's hard, but we don't wait for the lab test unless we have a clear historical reason to believe that a patient would have abnormal blood coagulation. So we treat right away. Patient comes straight in, make the diagnosis, straight to the CT scan, treat the patient in the CT scanner. We can treat most of our patients within 30 minutes of arrival at the door. So can you.
So the 30 minutes is not a goal, but just the real time.
The standard, yes.
Yeah. Wow, great. Yeah, we are running very hard to make it less than 60 minutes, but it is still very hard to achieve. Anyway, next question is Professor Tora. It is, do you have any existing third-party private clinical trial organization that could assist in patient recruitment, data collection, etc.? Kazu?
Sorry, pardon? Tell me your question again.
Yeah, you can read it in the monitor. So the question is, do you have any existing third-party private clinical trial organization which could assist in patient recruitment, data collection, etc.? Actually, in Korea, there is many CRO. Yeah, so how about in Japan?
So your question is about the system of trial management, right?
Yeah, I think so.
Probably in Japan, there are some shortage of human resource or infrastructure regarding the trial supporting system. If the company, pharmaceutical company, do the trial, there are plenty of supporting system. But if we ourselves want to start clinical trial, we often suffer from the shortage of human resource for the trial assistance. So, probably, I guess, you Korean researchers have somewhat better situation regarding trial performance than Japan regarding the investigator-initiated trial. Okay.
Okay. And there's another question from the audience to Michael again. And what is your opinion on the potential therapeutic effects of narinetide in other neurological disorders such as the traumatic brain injury, epilepsy, and so on? Michael?
Right. Again, great question. A lot of the data are preclinical. However, I can tell you that narinetide does seem to have activity in trauma. So in a percussion model of brain trauma in the rat, we can see benefit in this population. It seems to help in hemorrhage. It may also be helpful in some degenerative conditions. We know that the mechanism of excitotoxicity is relevant, for example, in ALS and even in Alzheimer's disease. And so, I don't know where it's going to go. I'm extremely hopeful that we get a signal here, because I think, as I said, it will really open up the possibility of a new therapeutic area in not only stroke, perhaps, but other areas of neuroscience as well.
Mm-hmm. I have one more question regarding the ESCAPE Next trial. So the design of the ESCAPE Next trial is almost the same with the previous ESCAPE NA1, except that it is not allowing the TPA infusion, right?
Correct.
Yeah. And then also I have another similar questions for the giving infusion method of the narinetide. Should we give it systemically, or how do you think about giving it intraarterial when we successfully achieve
so great again, a wonderful question. Thanks very much, Professor Rowe. So I think the truth is we don't know, right? It could be that it's better to give it intraarterially. However, pharmacologically, we know that if you give it intravenously, it certainly gets into the brain quite well. So it may well be better. I think that's the next thing. So many things to learn if we get a positive result to explore exactly those questions.
Mm-hmm. And another my personal question to Professor Dura.
Yes.
So I wonder if there is any clinical trial about the silostazol is planned or scheduled using the GAINS network in the another countries outside Japan. That might be very helpful. And
Yes, I think silostazol is very powerful and very promising drug, but there are big limitation in Japan. Now the patent by Otsuka pharmaceutical company was gone. So now, the company is not so active for doing trials. But so again, we need to do trial by ourselves regarding silostazol. So, but I have some plan, and I really want to do such trial using silostazol all over Asia or all over the world. So if I get a much amount of funding, I will start. But please help.
Yeah, I think that kind of trial should be one of your bucket list in your life. Yeah. Yeah, and there's another questions to the ESCAPE Next trial. One question is regarding the sample size and endpoint and very practical questions. Michael?
Sure. Yeah, right now, the sample size will be 1,000 patients, 1,020 patients. The primary endpoint is the standard acute stroke trial endpoint of the modified Rankin scale at 90 days. It's a binary outcome 0-2 versus 3-6. And we're looking for approximately an 8% effect size in the absolute proportion of patients who are going to get to independent outcome, Rankin scale 0-2.
Okay, and there's many similar questions. Do you have any plan to extend the next trial to Korea or other Asian countries?
So, I mean, many of you will, or some of you will know that Escape NA1 included sites in South Korea, in Seoul and Incheon and Daegu, and so I would love to. It's really just a question of what's happening with COVID and insurance and it's all practical stuff. If we can, the answer is a definite maybe. I would love to, but I'm restricted by the practical stuff at the moment. We're going to see how that changes over the next 6 months with COVID-19. So, I would love to, right?
Yeah, I also think that if there was no COVID-19, then probably many Asian countries would participate in the Escape next trial.
Absolutely right.
I think.
I mean,
And it should be the final question for the time remained. Do you have any clinical data regarding the concomitant use of the Ranitide with mechanical thrombectomy?
Oh yes, maybe I didn't make that clear in my lecture. Thank you. The Escape NA1 trial, which was completed and published earlier this year, included only patients undergoing mechanical thrombectomy. So in fact, all of the data in acute stroke patients includes patients undergoing mechanical thrombectomy. And I think that's the critical concept, is that we're now testing this drug in the human ischemia reperfusion model, which is defined by mechanical thrombectomy.
Mm-hmm. Okay, so the question from the audience is now almost done. And lastly, I want to thank you all our distinguished speakers. And thanks to Kazu, because I was very impressed by your insight about the Asian contribution of the stroke science. So, yeah. And also, thank you again for the announcement of the next 10th joint Korea-Japan joint stroke conference next year. I'm waiting for that. And also, thanks Michael again for your excellent review for the not neuroprotection but cytoprotection. I will use that term. Very like. Yeah.
Thank you very much.
Thank you. So the time is up. Yeah.